Great, welcome everybody. And it's really lovely to welcome back our friend Carol Davis, who's talking to us from America. And many of you know Carol's wonderful work. And today we're going to be discussing fascia and emotion and the autonomic nervous system, how we can work with it, how we can palpate it, and how we can engage with our clients with it as well. So welcome, Carol. Thank you so much. Carol, do you want to just say a little bit about your background and how you work, perhaps with this a little bit, and then I'll explain how I approach it maybe. Is that all right for you?
Yes, fine. That's great. Thank you, John. It's so
Thanks,
good to be
Carol.
here again with you and with my friends who've come and my people I haven't even met. Welcome. This is a really interesting topic, I think. I find it fascinating. My background is in very traditional physical therapy. I graduated, however, from a master's program, the very first master's program in the United States. So I have a background in neuroscience, and my master's was really in neuroscience and biology and physiology, because I was getting trained initially or educated initially in physical therapy. And so I went on with as a clinician, treating patients, particularly those with neural involvement, paraplegia, quadriplegia, hemiplegia, Parkinson's disease, multiple sclerosis. We were just moving at that time in 1969 when I graduated out of a predominant direction of polio treatments, moving more toward, since the vaccine had been enforced, moving more toward central nervous system deficit. And we were trying to understand the nervous system in a new way. And so that's always been my interest. So I practiced about 20 years at different clinics, and then I was invited to become an academic, a faculty member, and I started on the trail of academia. And but my interest was in the interaction between the therapist and the patient, and between the teacher and students, neurologically and otherwise. And so I went back for a doctorate in looking at what are the roots of compassion, and how can we understand how some healthcare practitioners get into healthcare because we want to help. That's just the universal thought. We want to help people. Our intention is to want to help and to be meaningful in helping. And then something happens. And my father had been through 2 years of randomized trials for cancer therapy, and he died not having been treated as nicely as I would have liked him to. That sent me back to graduate school. I wanted to see, as a teacher and as a clinician, could I impact what I called therapeutic presence? And so I've always been concerned about emotions and the intersection between intention and attention on the physiology, especially the neurophysiology. That's when I was separating it out, before I knew much about fascia, of the patient. And so now, in 1989, I was introduced to John Barnes' work, and I perceived this work as a whole paradigm shift to 20 years of my understanding of the nervous system and what might be happening, especially as it responds to manual therapy. Barnes' principles are very specific. They always have been since 1989, in advance and before, because that's when I came upon him, but he'd been teaching for a while. They were in advance of the research that really revealed that we have much more impact on the nervous system than we thought we did. In the old days, for physical therapists, the best thing that we could do is try to reintegrate reflex response. For example, if a patient had a hemiplegia, a left CVA with right hemiplegia, speech problems, and the hemiplegic arm and inability to walk, What we wanted to do was get the reflex dominance that came out from central nervous system insult so that there be more balance. We thought of it in terms of balancing the imbalance. Barnes started to help me realize that fascia and the embedded nerves within the fascia, and all of nerves are embedded within fascia, are going to be responding to compression and elongation through subtle energy. And all of a sudden, a whole world of quantum was open up to me. And that really started a different shift in my career. So from 19, I'd say, well, 19, I got so scared I had to stay away from it for 5 years. And then, because I knew I was getting into dangerous territory, because you can't use randomized trials to prove your outcomes. And physical therapy at the time, and still, depends a great deal on turning to the literature of what the literature says is valid, a valid approach to changing the system with the experimental variable that you're using, and whether you can show through matched pairs and clinical trials and controlling for variables that what you did really made the difference. I began to realize that this was ridiculous, because it might work for pharmaceuticals, but it doesn't work for human beings. So then I went off on the path of just trying to understand the histology and the quantum physics and the systems theory and holism, and then moved into biotensegrity and Steve Levin's work, and understanding mechanotransduction, and understanding thixotrophy and the piezoelectric effect. And so James Oshman, and to some extent Robert Schleip, with his understanding of piezoelectricity and thixotrophy, Pollock, and those folks doing that research was much more meaningful for me. So here I am today, kind of putting it all together. But all of that is to say that it is everything that we say here today, John, I think you'd agree, is based in our best speculation, our best hypothesis. Because we really don't know much about memory and about trauma. We have a lot of people to go to now, more than ever, especially with the vagal nerve studies, the trauma studies. Peter Levine has been focused on this for a long time, even more. And with Bud Craig's work on interoception. So I have come to see that this work that we're going to be talking about today really gets to the heart of healing. And Barnes says this too. Barnes says you cannot heal from left brain logic. No. You've got to engage a patient's or client's consciousness at whatever level, whether it's your infants, John, that you're working with, whether it's people who are in coma, whether it's older people who are not responding sensory-wise as they used to, whether it's working with animals. You're trying to engage that aspect of our essence that is fueled by subtle energy and lives in the realm of what I call really compelling storytelling. Telling stories about the mystery and how could that be working? How could I get that kind of response? Now, there is some data that's coming out that's very compelling. That's functional MRI of interoceptive response to the therapist. So we may get a chance to talk about that too, but that's enough about me. I engaged in storytelling. a long story about how this topic is even more central to my heart than all of the orthopedic or neurologic physical therapy that I practiced for many, many years. I'm very, very glad to have discovered Barnes, very glad to have been on this journey. And it's nice to be celebrating it here with you today.
Oh, thanks, Carol. Yeah, so my background is a craniosacral therapist and a Bowen therapist. Now, I'll talk a little bit about the different approaches as we go along there, Carol, in terms of how you might approach this. But my personal interest with it really went back, a long way. I got involved in therapy, which later became sort of body psychotherapy. Although at that time, this is in the early 70s, it wasn't really, it wasn't thought of as body psychotherapy. It was something a bit more radical. It was through the primal, do you remember the primal scream?
Yes, yes.
Yes, so it was that. And so he touched on the relationship between the autonomic nervous system and the body. At that time, I didn't really feel I had a body at all. So there was a disconnect. And I also wasn't from a medical background, so I didn't understand my autonomic nervous system at all.
Yeah.
It's really only from discovering Stephen Porges' work that it kind of put it into a context about what was actually going on. So, and I think we can touch a little bit on that as well.
Yes.
But what helped calm my, I suppose I was interested from a personal point of view because of certain things that happened in my sort of early teenage years, which were really traumatic. And I was trying to find a way of dealing with it through my body because I didn't know any other way. And so I experimented with a lot of body-based things, a lot of breath work and rebirthing and hands-on therapies, including craniosacral. And craniosacral was the one thing I would say that was very relational, which was very good for me because it allowed my nervous system to settle in relationship, which it didn't normally do. But it also reminded me, or reminded my body somehow, of sort of deep states of meditation. And I got into meditation when I was quite young, and it was the therapy really that kind of enabled that deep settling in a somatic felt sense, in a safe way in my body. And that was the thing that I think shifted something. So, obviously Porges talks a lot about that, the need for safety in relationship and therapeutic relationship, all that kind of stuff, which was so important. I didn't know anything about that at the time, but what I did know was there was something about deep stillness that I experienced in meditation, and then coming across craniosacral work, that I realized that in a therapeutic situation, you could share that space with someone, that somehow there was a kind of resonance that built up. And the fact that someone else is putting their hands on you, which is a very intimate thing in a way. It's an unusual thing, isn't it, really?
Yes.
And then it felt like, and I certainly felt this then when I learned craniosacral therapy about 30 years ago, that it felt like it was a journey that both the practitioner and the client went on together. It was almost like a shared journey into stillness. I mean, there's much more to it than that, but that was what drew me in. And then coming across Porges' work, it kind of made sense about how the autonomic nervous system works, and then being able to influence it in subtle ways through manual therapy. And certainly when I came across Bowen, again, I didn't understand it at all, and I think a lot of people didn't understand it, but realizing that Bowen had a similar ability, if you did it in a certain way, to put people into a very deep sort of vagal state, or parasympathetic ventral state. And that really intrigued me, and so that's kind of what I do. And you mentioned about working with babies, and of course they exhibit all kinds of things, particularly obviously traumatic births and things like that. And I think, you mentioned about trauma and memory. I think we had Jaap van der Wal doing a course for us last couple of weeks on our sister site, Our Birth Journey. And it was just so interesting coming from his perspective, because, he's been involved with the fascia world as an embryologist for years and years and brings his extraordinary knowledge and expertise. But to hear him talk about this thing about memory and, you know, where does memory begin? Does it require a nervous system? You know, all these are very complex subjects. I think are absolutely fascinating. So yeah, so in terms of Barnes's work, then, Carol, how might you? I'm just wondering how you might pick up from that work, what's going on in someone's nervous system, how we might perhaps begin to work with that.
Yes, we really are kindred spirits. We came at this in very similar ways.
Yeah,
John. One of the things that Barnes says in his teaching is be like a curious cat.
nice.
And if you go into the room knowing exactly what you're going to do, you don't know what you're doing. So the idea that Barnes teaches to us is the principle of deep listening. He calls it a channel 3 listening, in contrast to channel 5. Channel 5 is the diagnostic side of our process of understanding what's going on. It's what we're taught in physical therapy as a differential diagnosis. And when we do structural myofascial release, we stand people up in front of a mirror, perhaps, and look at where the malalignment is, and then get them on the table. And from what we've seen in front of the mirror, then we start working.
Yeah,
That's a novice way of responding to fascial restrictions. And it's what we do in the beginning, all of us, I think most of us. But that's not true myofascial release, according to Barnes. The principles of Barnes would be, I come into the room totally knowing I'm crossing a threshold into a whole new experience. And that crossing the threshold is liminal experience. I let go of everything that happened already in my day. I've already prepared the room for a lowering of sympathetic overload, because most of my patients come to me with pain, and they come to me with some agony about that pain. And they come to me after having tried many other disciplines, and many of them are very suspicious of why would this be any different. And so soft lighting, soft colors to the walls, off blue, a light blue, and indirect lighting. And I come in, and the person's sitting, and I sit across from them, and I ask, what brought you here today? If it's the first visit. If it's a second or third visit, I say, what is different today than the last time I saw you? So I can orient people to the here and now, right here, without my diagnostic process. I mean, mine might be noticing rounded shoulders, a high shoulder, something going on posturally, but I want to hear what the patient's feeling and what the patient's perceiving as problematic. And then through listening carefully, and we work on the skin. So I ask them to take clothes off, except for bra and shorts. And then I decide in that moment of dialogue, where am I going to start? And I know that I'm going to start where fascia calls to me. Now, this is the real, there she goes. But there is a sense in which, if I'm down in my channel 3, not in my logical left brain, but I'm listening carefully with the intention of helping, with awareness to what posturally, the tone of the voice, the posture, the attitude, affect that the person is giving me, where is it that I want, where am I drawn to, is a better way to put it. So I might start with them sitting right there in that chair. Or I might say, let's come on up, stand up for me. And I look to see how standing in gravity shifts what I'm perceiving. And then I ask them to lie down on the table, either supine or prone or side lying, depending on where I might want to introduce touch into the entire system, head to toe. And then let's say they're supine and I can feel the tension. I can feel the sympathetic overload. And so the first thing I want to do is introduce something that's going to bring sympathetic down and parasympathetic up, because this is a binary system. The autonomic nervous system is listening to one or the other predominantly. And I want to balance things out. And one of the fastest or finest or loveliest ways that John teaches, Barnes teaches, is to just very gently, hands very gently on the body, on the whole fascial web, just very gently introduce a kind of a rebounding energy. And it's not push, it's let me see how the system responds to my push, let go, push, let go. Push. I'm sure you have something that's comparable. And I think it's very close to Traeger, from what I understand from Eileen about what Traeger is getting at. It's how is the whole web reflecting with subtle energy this new energy that I'm inputting. Now, how the web reflects it has everything to do, I believe, with the response of my energy and my input. As soon as I walked into the field, the body knew, whether the person's aware of it or not. Something's going to happen here. People are very attuned to the energy. And what I want is resonance. I don't want conflict. I want my energy and the person's energy to resonate so that I can use that in my understanding of how I might elevate the parasympathetic and lower the sympathetic tone. And then I watch, and I may do this for 10, 15 minutes, very subtly at first, and I might do it as a rocking side to side. I go up to the shoulders and I do it head to foot or down to the feet, and I do it feet to head. Again, with the cranial rhythm, you teach, I'm sure that you can feel that rhythm from the feet, from wherever you are on the body. I'm trying to recognize where fascia might be inviting me. And then if I move into structural work, sometimes with the rebounding, they'll go into an unwinding. I ask them to breathe deeply, and I get them breathing from a full breath from the belly up to the shoulders, a full breath. I don't say a deep breath so much because that can be interpreted many ways, but a full breath from the belly up to the shoulders. And sometimes they'll go into a kind of a spontaneous movement, and they'll say, what's that? I said, just stay with it. And then I move in to support getting gravity out of the system, supporting whatever extremity or however they're moving into whatever posture. I said, just go with it. I'm right here. I'll keep you safe. I won't let anything happen to you. Just follow. And if they do go into an unwinding, maybe they have a moment of state dependent recognition. They were in a rollover accident, or they fell out of a tree, or they fell off their bike, and all of a sudden they want to be upside down. And I'm supporting them in this process. I'm not freaking out because I've been doing it for so long, but the young therapist, now what do I do? Now what do I do? Just keep them safe. Just keep them safe and go with it. This is true healing. They're releasing stuff that the sympathetic nervous system has just kept down. And then they get to a still point, and then the emotions might take over, and I let them cry, or I just be with them in that. Or they say, well, that was really weird. And they get back up on the table and they lie back again and say, what was that? And so I talk a little bit about what might be happening your body in a way that fascia knows in its wisdom. But then with more structural manual work, Barnes teaches you meet the person where they're at. You press lightly where you feel hard, hot, or hurting, and you feel for changes in fascia. Now, that doesn't necessarily mean there's a pathology there. It's really more about what's fascia doing to support this person in the very best way it can. Where's the imbalance between tension and compression, which is the biotensegrity sum total of body energy throughout the whole fascial web? Where does it need more compression? Where does it need more tension? Barnes teaches compression down. Take a breath, and then without sliding on the skin, open up your hands until you come to a dead halt over an area that you think might need help. And then you wait there. You don't wait there for 60 or 90 seconds. You wait there for 3 to 5 minutes, feeling the unwinding, local unwinding of the fascia under your hands, tuning in, getting out of your left brain, getting out of do I have to pick the dry cleaning up after I leave, or getting out of all that stuff and just being with fascia as it responds to the subtle energy and the infrared energy and my bioelectric and biomagnetic field, electromagnetic field on the whole process. And I just stay with that. Very often what happens, especially when I'm doing cranial work, and I'll finish with this, John, what happens is I and the patient go on a journey, like you say. We go to some place that is so soothing and so responding to the whole of the fascia, from the whole of me to from the whole of the person, that Jaap would talk about. That's really what we should be talking about, not the anatomy parts, but the whole, the mysterious. And then I let myself be in that space. Oftentimes it's when I'm balancing the sphenoid at the end of the treatment, because all of this comes up and inserts, right here laterally in the cranial area at the wings of the sphenoid. And I'm balancing that to make sure that the sphenoid can have its rocking motion to milk the pituitary when my patient or client gets up off the table. And then when I'm finished, I ask, how was that? And I have no expectation. I try to let go of the outcome. Of course, I want to be helpful. If I'm not, I let that go, and I'm off to wash my hands. And that's how I'm responsive to emotion and fascial language, according to the principles that I've learned from Barnes.
Wonderful. I did a chat with Robert Schleip the other day, and he was talking about this new research he's doing on depression and fascia. It's very interesting. And he said he's developed these sort of artificial, I don't know what he's made it from, but of fascia where one has more stiff quality to it, and the other, less stiff, and he was getting people to feel it. And anyways, it was interesting how he's looking at it, because obviously there is, we know about the action of things like myofibroblasts, don't we, in terms of stress, and how everything gets stiffer, and also how the pH quality in the body changes in response to stress and anxiety and things like that. So, and then we can kind of pick that up, can't we? I suppose but from a craniosacral perspective, it's very difficult. I'll try and put this into words, but it's actually quite difficult. I suppose because, well, you've been doing this longer than I have, but when I've been doing it for nearly 30 years, so there's some experience there. But there's, you can pick up so much, can you? I always think that really, with this work, the sky's the limit. If you mentioned about listening deeply and getting out of the way, the more we can do that, the deeper we can go with people, really. And that's for me is the key. So obviously, I suppose I do quite similar to what you're describing at the beginning, and you're talking to someone and you notice their breathing, and you're noticing how fast they're talking, and what might trigger them. So if they're talking about a particular event, how their face might respond to that, and how the voice might change. and things like that. And when they're on the table, I find very often I'm always intrigued by things that I feel which are unexpected that come through my hands. I feel they possibly have a bit more reality rather than what I expect to feel.
Yes.
What I expect to feel is very different to what I actually feel.
Right.
So I like that. And so a common hold that I use, and this is not really a standard classic craniosacral hold, but I might hold under their lower back and sort of just at the top of the thoracic area around the spine. And I quite like that hold because in that hold, you're kind of holding their, sympathetic nervous system, the spinal cord, etc., and kind of tuning in. And so from what I tend to feel is, it's a bit difficult to describe, but tuning in, say, to the fluids, cerebrospinal fluid and what they're doing. So when someone is sort of like their sympathetic system is quite agitated or up, there tends to be a sort of what I feel is a kind of like and they often feel it. It feels like being on a kind of rocky boat on a sort of, you know what I mean? It's like everything is like this, or there's a sort of perturbation in the fluids, like they just won't settle. And I often find this with people in chronic pain. What I find really interesting is that very often when you work with kind of intention for their system to sort of deepen into the couch and their fluids to kind of settle more perhaps into these slower tidal movements like the mid-tide or that's even the long tide. But when they take up that intention, many times they'll say, oh, my pain's gone, which I find really interesting, that there's something that happens when, because obviously in a chronic pain situation, the nervous system is quite active, isn't it? It's like it stimulates the sympathetic system and it's, it's like on red alert. So, and it also, what I find is that it allows the body to have another possibility that's always there, really. It's just because they're kind of cycling within that, their bodies don't remember it, they can't access it. So part of what I feel is that, oh, we get the body, oh, they can remember this is what I can do. I can go there. I can allow my system to settle. So I find that, so the way I might feel that is a kind of like a buzzy quality in the fluids or just a perturbation. And then just I find the intention just for things to slow down, as you say, like tune into the rhythm as well. That often really helps, to kind of settle and deepen and allow it to dissipate. And then the other thing which I find,
John, excuse me, before you go on, can I ask you, what's your direction to the patient or client to do that? What are you asking them to do?
Oh, that's a good thing. I mean, it's a good question. I think, like you, maybe, with the breath, breathing through their nose deep into their tummy, sometimes those kind of things can help. But normally I might be dialoguing with them, because you're trying to, I suppose, get them to have a somatic sense of what's going on. And
so direct your attention to, or
yes, direct your attention to some place that feels safe, or their breath or something like that. But I mean, I know different therapists work in different ways, but sometimes I'll be quite quiet with it because they seem to go into a kind of different state with it.
Through your touch.
Yeah. And then the other thing I tend to work with is, working with a kind of CV hold or a cranial hold at the occiput. I find very beautiful because I guess, again, from Porges' work, we're holding the brainstem, aren't we? We're holding, all the nuclei of the vagus there. And also then we're holding the fluid bed, you could say. And also then, so my attention will be through to their whole body from that place. And then again, I might feel some interesting, again, it's slightly difficult to describe it, but the way I feel it sometimes, particularly when people are holding trauma, and I think when they're holding trauma, that they're basically holding something they can't integrate, aren't they? I think a lot of times when people come, what they're bringing is something they just can't integrate. They can't find any resolution. So what I feel is sometimes that you're holding their head, and there's this kind of almost like that. The closest thing I feel to is if you were in an aeroplane and you're going down through, like through the clouds, and everything begins to do this, and it's kind of like all over the place. It's like it's like kind of rocky.
Well, that's a great, that's a great comparison. Yeah.
Like that. So I'll feel that, and then I might dialogue with them about what that feels like, and I might feel perhaps this is related to something at a specific time. Sometimes things feel very early, and I don't really know why I can feel that. Sometimes it feels a bit more recent, but anyway. But that process seems to have a bit of a life of its own. If to stay with that, and it's very kind of much like, it feels very embodied, it feels very much in the fluids. So stay with that and just let it settle, intend it to settle. And at some point it feels like, oh, the whole system settles and everything begins to spread out. And it's at that point that their nervous systems feel like it's settling, and quite often they'll breathe it, their breathing will change. That, they might do a sigh, or they might, they might shed a tear, or that's kind of like how I might work with the cranial. But with the Bowen work, it's kind of different in the sense that it's slightly more, I'm sure you've had Bowen, haven't you, Carol? So you know what it's like, that it's there's not so much contact, the kind of contact that you're talking about, in the sense that you are working on the fascia and then leaving them for a response, and then doing a bit more that kind of work. And so with in terms of influencing the tissues that way, I think there's quite a lot you can feel. And there's quite a lot you can notice when you're working, particularly up the back. We tend to work quite a lot around the spine. So you can see perhaps how the sympathetic chain is responding as well. And sometimes, sometimes you've been working up their back and there's an area of tension in a specific area there. But the way, I suppose, is that we work with it in that way is more through working with the receptors more directly. So, for example, I know Robert Schlope talks a lot about this, how we might influence the Ruffini receptors and how they affect the hypothalamus, and increase vagal tone that way. A lot of our Bowen moves are around joints, around the back, where there's a lot of these kind of receptors. So if I wanted to influence that more, I would, on a more conscious level, I would slow my movements down. I'd sink deeper, and I'd do a longer kind of cross fiber challenge on the tissues. And I do it more with their breath, really encouraging to breathe through their nose deep into their tummy, and do generally slower kind of stuff. I think the other way into their autonomic system is through very light touch as well. And again, I know Robert talks about that, but yes, through these interstitial free nerve endings, where you're stimulating. Some Bowen works on the periosteum, really. So we work, so for example, around the coccyx area or around the head, where you're influencing those free nerve endings really strongly. And I like that kind of work, particularly with people with chronic pain, because you don't want to stimulate their sympathetic system anymore, do you? In that kind of situation, you just want to calm things down. So that kind of approach is a little bit more, I would say, less feeling based. It's more, okay, I think this person needs this, I'm going to work with them that way, and I'm going to see what the response is. And generally speaking, I find with very often they'll go to sleep, which I like. Yeah.
Now,
So
something that you said confused me. You said,
yeah.
It's what you just said, that sometimes you'll go very deep with the Bowen work with the periosteum, which is to me going very deep.
Yeah, well, I would say we work with it more where it's more
Close to the surface.
yes, exactly, more superficial. So for example, like around the coccyx area, it's not, there's some stuff we do around there, around the head where it's yeah, more exposed. So I don't mean going deep really, in that sense.
There
and
is
around the chest, for example, around the ribs. So
there is a predominant view still, that if you want to impact fascia at the periosteal level, that you use a lot of force.
really? Oh, that's interesting.
Yeah, that you, in fact, I've heard people say that when you want to get down into the deeper levels of the myofascia, toward that are around the bone, then you have to push very, very hard.
Really? Oh, we don't tend to do that. I mean, that would be painful, right? I mean, with someone, I'm talking about particularly people with chronic pain, they seem to respond quite well to this. People like with fibromyalgia and stuff, where their nervous systems are like on red alert, you do want to hurt them, right?
I think that that's true of everyone.
Yeah.
I don't hold with those people. I don't hold with that idea, because I hypothesize, I follow the principles that the energy is doing the work, not force.
Sure.
And there are times when we use a kind of a tearing of the cross tissue, the J stroke or an elbow, in order to be able to heighten the circulation to an area. But that's not the predominant way that Barnes teaches. No. It's really more toward a very sensitive light touch, and then the energy will go deep, 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 as far as it needs to go through the whole web, not just even in the area. And there's a wonderful thermal camera video of Richard Harty, H-A-R-T-Y, on YouTube. Did a cross hand release over the knee. Oh, really? And he has a thermal camera over his hands. Oh, cool. And his fingers start out very purple, and the body, of course, is orange and yellow because it's 98.6. As he maintains his gentle pressure, just meeting the person where they are, you can see the temperature changes happening, not only in the person, all up and down the leg, in his arms, in his hands.
What was his name again, Carol?
Richard Harty, H-A-R-T-Y. And if you put it on YouTube, something like Richard, what do you say? Thermal camera and myofascial release.
Oh, yeah.
It might come up. I use that all the time to make the point that it's a kind of an understandable mistake that we make when we come from solid state physics, which is what we learned, that the body's a machine and you treat it like a machine and you're working on parts. That's not it at all. The body is soft tissue, all soft tissue. And I hold with those who say even bone is soft tissue. And that when you want to impact soft tissue, you impact the state, the physiological state, from stiffness into more compliance through subtle energy, through thixotropy, through mechanotransduction, the influence of energy, our energy, on the whole system, no matter how deep or superficial. But light touch is always indicated to do the majority of the work, and 99% of the work, and that the inner connection of the person is really where the focus needs to be. I never have received Bowen, so it was interesting.
Oh, okay.
I have talked to Kelly several times, and I say, Kelly, now explain to me again what you're doing and why you leave, because I have. Is
this Kelly Clancy, you said?
Yes, Kelly Clancy.
Oh, cool. Yeah.
I have had body talk, and I know that the person left the room, and I thought, well, this is strange. The first time I ever got it. And she said it's a chance for the inner web to reorganize the information that's just been placed. And as I understand it, that's to what you're doing in Bowen, is it not? That you're asking for, and Schleip suggests this too, because there is it's multimodal impact on the nervous systems and on the myofascia. And fascia has then a chance to react and respond, mostly respond to this input if you step away from it for a little bit.
Yeah.
I will change position of my hands, but I don't step away from the person. I don't think I've ever done that, but I wouldn't be surprised if I got an intuitive hit.
Right.
And I love the way you talked about that. I don't know why I did that, but we get these messages that I'm projecting onto you. Is that what he meant? There is something about the wisdom of this field that becomes present to us. And this is of course speculation about the field and wisdom in the biofield. There's some interesting research being done now by Shamini Jain, Jain, and also Beverly Rubik, Rubik. If you want to look up biofield research, Rubik is a rigorous researcher who has been looking at biofield therapy, and Reiki being a predominant, polarity therapy is another one, non-contact therapeutic touch is another. These therapeutic approaches have off the body as well as on the body have some significant outcomes that are difficult to explain according to objective measures, but that they're very real. And so once again, I want to remind people who are listening to us, we are hypothesizing here about where memory is stored. We're hypothesizing about what's really responding to our touch. We know some of it, and some of it I will stand behind because of the solid histology and the whole concept of cytokine response, immune system response, cortisol measures in saliva. Andre Pilot has done some of that work with what he calls myofascial induction, which is really Barnes, I think, oriented myofascial release, sustained release myofascial release, and he looks at cortisol level changes. Paul Standley, Standley at the University of Arizona, has done cytokine research looking at interleukin response at 3, 4, 5-minute intervals of sustained compression in vitro and elongation. So some of this is, the more we get into the threshold of consciousness, and the more we get into the threshold of AT still saying fascia is where the soul dwells.
Yes.
Then, and of course, that's where Jaap wants to live now, and with some fervor. I don't want to try to represent Jaap van der Wal. It's the way I read Jaap now, saying we cannot continue to look at fascia and bones and ligaments and tendons as being separate. We have got to look at the whole self-organization, everything all together. And of course, this opens us to mystery and opens us to where is that intelligence being driven from that enters our body at the moment of conception. This is Steve Levin's work in biotensegrity, the push-pull sum of biotensegral energy as we self-emerge and self-develop and self-create ourselves in utero according to the DNA blueprint. But the DNA doesn't do it. It's the energy that comes in from the egg and the sperm directly, the biotensegral push-pull that is with us from, I believe, the moment of conception until we take our last breath. That then becomes, where is the intelligence that coming from that drives that? And that's a mystery that I don't expect to have the answer to, and I'm not sure that I really need to. The more we learn about it, the more excited I get, and the more we can say, yes, That's crystalline water. That's what happens to collagen when the H3O2 binds to the little projections in the spiral in the left in the helix, and then you get easy water, and we get batteries, and when you're pressing on it, the electrons are flowing all over the place because they've separated from the H3O2. It's not solid. It's not stable anymore. Well, you can see how excited I get about the science. I mean, when you've got scientific pieces coming together like that, proving what Barnes intuited many, many years ago. I've been talking to him about that a little bit. How did you know? How did you? He said, I just saw it. I intuited it. It was a wisdom inside of me that I wasn't willing to give up because there wasn't science. There wasn't science to justify it. I waited until the science came forward. And that's what I've been doing since 1989 and before, trying to understand the science.
I think a lot of these guys, I mean, 80 still was very intuitive. A lot of the stuff he developed was, he admitted was intuitive, and certainly Tom Bowen was, and I think Ida Rolf was as well, probably.
And Traeger as well.
Yeah.
Can you feel the air around you? I love, Eileen taught me, Traeger says, when you're getting ready to be present, go to a place where inside, can you feel the air all around you? And that will get you out of your left brain pretty quick.
Beautiful. So Jihan is saying that he's very much involved with the fascia world, as you probably know. Thank you, John and Carol, for this great webinar. Just for your and everyone's information, Gary Carter and I did a wonderful dissection in September 2020, where we dissected the superficial and deep adipose tissues of a cadaver form and maintain connections to the key bony landmarks. It was incredible to see how close to the surface the periosteum exists, embedded into the tissues considered to be more surface tissues.
Yes.
It wasn't just the areas of the coccyx or occiput that we contact with Bowen moves easily, but many more, as I'm sure you'll know. But to see these bony landmarks so close to the surface was a wonderful opportunity through dissection. Some of the places were quite surprising. So that's
I imagine. So it's good to hear from you, Jihan, and I know that must have been really, it's so nice for you to bring that forward now with this discussion. Thank you very much.
Yeah.
And I remember working with John Sharkey in his, I don't know whether you were there that time, Jihan, with his fascial dissection. And Christine Wuski and I were looking at the tentorium cerebelli and how it was stuck to the periosteum on one side of the internal cranial periosteum and loose on the other side, and how that would impede the flow of the ventricle fluids around the meninges, and why it's so important to do that gentle cranial work to open up as much as possible the cranial vaults, so that craniosacral fluid can flow from the meninges and out around from the ventricles out around the meninges and down the dural tube.
Yeah. And that's very much affected by birth. It's one of my passions. I'm talking to the Polish Fascia Symposium soon about it. But you know, certain types of birth really, I mean, apart from being traumatic and affect the autonomic nervous system massively, but they have a particular effect on the meninges, I would say, and the venous sinuses and that kind of stuff.
Yeah.
When you know, we know about forceps, but particularly when you go into things like suction or ventouse, how that puts local pressure on the tissues, and very strong tractional forces, you know. Tends to affect
and that. It's so soft, such soft tissue.
Incredibly,
and such powerful forces on it. Yeah.
So I mean, from my perspective, a lot of the stuff that we're talking about in terms of how people's autonomic nervous systems are kind of set up or programmed, almost, if you want to use that word. I think it starts very early. I mean, I think a lot of it starts in the womb, as when we maybe get used to, you know, you mentioned about levels of cortisol and all that kind of stuff.
Yes, absolutely.
That mums might be experiencing. And then obviously, or particular traumatic events that might have happened in the womb, you know, as we're forming. And I think then with these very early experiences that might happen in the womb or in the first year or around birth, they tend to be the things that kind of run us quite strongly in because most of these things are unconscious or pre-verbal.
Right.
That we can have a general sense of perhaps feeling unsafe in our nervous systems,
Waiting for the other shoe to drop.
yes, anything like that we don't know, or something that happened at birth that creates these kind of things, because birth is it's a life or death situation. It's a key thing where our autonomic nervous systems get really, really heavily involved with.
Right.
Our sympathetic system is pretty active at birth. So so I think these things can get very imprinted. And one of the things I'm very interested in when we're talking about the autonomic nervous system is how these early experiences get convoluted with and sort of combined with kind of belief systems as well. I find that very, very interesting, that often a kind of nervous system trigger will also trigger a belief system about how safe this world is, how good a person I am, how worthy I am, all these kind of so what you're talking about is this big picture. It's not just, when we're talking about the autonomic nervous system, it's not just that. It's a whole body and a psyche response, isn't it? It's not just your autonomic nervous system doing something. It's much, much more than that. Yeah.
And all memory is colored by previous experience.
Yeah.
You can't have a pure memory. And
No, and I
belief
think that
comes into it. There's the limbic system, the hypothalamus and the amygdala coloring the perception that you're having in the moment, and the memory of past experience, whether you cognitively remember it or not, it's there.
Yeah,
and it's triggered by all kinds of sensory experience, such that now there is a predominant belief that there is no such thing as objective pain. Pain always comes with that baggage, with that belief, and that limbic system overload.
Yeah. No, it's absolutely true. And I think that even happens with babies. I know that one might consider that babies don't have much previous experience, but actually I think even in the womb, they're having lots of different experiences. So there'll always be this thing, have I felt this before? What is it like? Is it dangerous? Do I need to pay attention? I know Lorimer Moseley talks a lot about this kind of thing in relation to chronic pain.
Yeah, that's very good. And of course, the more we can do as therapists to help people feel safe and to allow them to go back and to go in and to reconnect with whatever it is that's continuing to traumatize them. Because the nervous system continues to fire until they can release that, until they can let go of that. That's our true gift. But separating ourselves from it, getting ourselves cleaned out, so we're not projecting our stuff, our trauma, our wounds onto the person.
No, absolutely. No, I think this whole thing about, it's such a powerful thing, this touch, particularly Carmen's saying about, how important superficial work is and gentle work is, because the thing is that some people can feel, and I think Bessel van der Kolk talked about this, how some people just feel chronically unsafe in their bodies. Bodies do not feel safe to them. So they've got this kind of gnawing sense of lack of safety. So the fact that we can put our hands on someone in a safe way is just that, if we did nothing else, is so powerful, isn't it? It's so powerful. So
they struggle to find the words to say thank you.
Yeah. Well, I think we're pretty much on the hour. That went very fast, Carol.
That went fast. And I struggled to find the words to say thank you for inviting me to be a part of rich conversation.
We could do plenty more, couldn't we? If you're up for it, we could.
Yeah. We could talk about our own early childhood experiences.
Oh no. No, we could do. No, we could do, absolutely. That'd be very interesting. I'll email
sympathetic
you
overload. And
Great,
thanks everybody for joining us. And the people in the chat are starting to chime in now. It's wonderful to know that you were out there, even though we didn't have a real discussion with you. Now, if we had another hour, we could just open it up and you could tell us about your childhood experiences and your experiences, your meaningful experiences with your patients. But I appreciate, John, very much the opportunity you gave me to talk about my patient experiences, because it enriches my life so much.
Yeah. Thanks, Carol. It's really a delight. Thank you. Thanks, everybody.